All right, welcome back. We are going to continue on with our next presenter, and it's a pleasure to have Dr. Klint Peebles with us today. He is a board-certified dermatologist with Kaiser Permanente Mid-Atlantic Permanente Medical Group in Washington, D.C. and suburban Maryland. Dr. Peebles primarily focuses on complex medical dermatology and also has extensive clinical leadership and research expertise in gender and sexual diverse health and gender affirming dermatology. He received his medical degree from Vanderbilt University and completed his dermatology residency at University of Wisconsin. As mentioned, he has extensive leadership surrounding advocacy and access within not only our American Academy of Dermatology, but many councils and other societies, including the American Medical Association, surrounding LGBTQ and SGM health, and also other advisory committees associated with the World Professional Association for Transgender Health. He has extensive publications in medical journals, serves on editorial boards and lectures nationally and internationally on dermatology and broader issues of gender and sexual diversity, as well as healthcare policy and legislation surrounding equitable access to gender affirming care and access to minimally invasive affirmation procedures, as well as the intersections of public health, climate justice, and animal welfare. And so I'm just so happy to have my friend, Dr. Klint Peebles with us today, and he will be talking on sexual and gender diversity, considerations for equity and inclusion in a changing landscape. Welcome, Dr. Peebles.
Thank you so much, Dr. Allen. Just want to confirm that you can hear me and see my slides okay.
Everything's great.
Perfect. Wonderful. All right. Well, thank you so much, everybody. I'm just so thrilled to be here. I just want to echo everyone else's comments that I'm honored to be in this wonderful lineup and the great speakers that you have and the work that you're doing. And please feel free to email me offline, get in touch with me in any manner. I'm always an open door in terms of communication. So just a few things. I have no relevant disclosures. No financial disclosures, that is. And here is my practice gap that I'll just have in the slides afterward for your viewing, and then my learning objectives. But as we talk about gender and sexual diversity, I know that's a huge gear shift for the content today, and I'm just so excited that we have the breadth of topics that we do and the multiple aspects of these issues that we're talking about as it relates to care for underserved and marginalized populations. And I'm just honored to be able to do this and that you have this content featured. A few other things. I do want to recognize my privilege as it relates to skin color, perceived gender identity, and ability. I do not speak on behalf of all gender and sexual diverse people. I'm one voice among many, hopeful to empower all those who wish to do this work, whether part of the community or allies, and we certainly need both. So unfortunately, in recent years, we've seen a lot of attention being given to the lives and well-being of LGBTQ people, but not all of this has been good. In fact, there's been a groundswell of efforts to limit the ability of these communities to live their authentic lives. And this is just a sampling of headlines from around the country and, in fact, the world that we've seen limiting the ability of people to live authentically. And there's so many stories of folks facing marginalization and rejection from the healthcare setting. This is an individual from right there in the state of Oklahoma, for those of you who are there, and was featured in the New York Times, candidly discussing their experiences with being able to access healthcare and not being able to access it in culturally humble ways and in ways that would actually be beneficial to their overall well-being. But before we get into some of the terminology and broader issues, I do want to go over some demographics. So basically, what we've seen is that the rate of LGBTQ identification in this country has been growing very stably over the last several years. At 7.6% identification as LGBTQ plus in the most recent Gallup poll. Bisexuality does make up the largest proportion of that population, and more than 1 in 5 Gen Z adults and 1 in 10 millennials identifying as LGBTQ. More than 1.6 million people over the age of 13 identify as transgender. That's about 0.6 to 0.9% of the population. And just to put that into perspective, compare that to the prevalence of type 1 diabetes in the United States, which is 0.3%, or those with systemic lupus erythematosus, which is estimated at about 0.15%. So certainly a population that is certainly deserving of attention and approaches to care that are going to be in their best interests. As I mentioned, gender expansive identities are more frequent among younger people. And certainly, we do see greater rates of gender diversity in areas such as urban areas and high schools, even more recently. In some surveys, up to almost 3% of high school students are identifying as gender diverse. There's even some institutions reporting as many as 10% of high school students identifying as gender diverse. And just to clarify, sexual and gender diverse people, LGBTQ individuals, have been around since the dawn of history. But what we're seeing in terms of an increased rate of being transparent about those identities is growing because of changes in social acceptance and conversation. And this is just to drive home the fact that we are seeing greater rates of identification with LGBTQ identities in the younger generations, successively increasing as we get younger. And this just kind of shows that in greater detail. Other demographics in terms of those who are identifying as transgender women versus transgender men, we see fairly equal, roughly equal rates of that, but we also see about a quarter of that population identifying as gender nonconforming. So perhaps non-binary or neither trans man or trans woman. And I'll talk a little bit more about those definitions in a little bit. But I also want to point out, really importantly, in terms of the racial and ethnic distribution of trans youth and adults identifying as transgender, in the sense that the identities of those in the LGBTQ community, there is a higher rate of racial diversification in these populations versus the general population. Now, roughly 40% of LGBTQ adults in the United States are people of color, including more than 10%, about 12% in the most recent estimates, who identify as Black. And this is also mirrored in the transgender youth population, where we still see a greater racial and ethnic diversity of people in the LGBTQ community versus that of the general population. So again, a lot of intersectional variables here. And you may think, well, what does all of this have to do with my own practice, my own life, and the lives of average sexual and gender diverse Americans? Well, 20% of LGBT people overall and almost half of trans individuals report discrimination on the basis of their identity when they engage with a healthcare setting. And almost a third of trans people avoided seeking care altogether when they need it. And that's coupled with issues of access to the correct insurance coverage, comprehensive coverage, even preventative services. And we even find these same concerns mirrored in formal complaints to the Department of Health and Human Services under the non-discrimination provisions of the Affordable Care Act with regard to denials of care, inadequate care, and other forms of discrimination. And also, to further hone in on some of those disparities, individuals of color within the LGBTQ population report even greater and more amplified discrimination on the basis of race and ethnicity than their non-LGBT counterparts. So you can see here that in terms of those identifying as Black reporting discrimination due to their race or ethnicity, more than half of those who also identified as LGBT reported that discrimination versus just 40% of those who did not identify as LGBT. And looking further at some of these disparities, when we consider the role of social determinants of health, and I love that you started out this symposium with a wonderful presentation from Dr. Okanlami. We actually see these disparities more heightened with regard to those living with disability in the LGBTQ population. So in this particular study, the PRIDE study, one of the largest studies done so far in the LGBTQ community, it was found that almost a third of folks are living with a disability in that population versus national estimates in the general population, which are just about a quarter. And LGBTQ folks living with disability are more likely to delay seeking care when they need it, not have health insurance, or just be unable to obtain care outright, and then struggle with getting appointments, struggle with cost, transportation, all of those types of things. And this is just one example of some of these social determinants. And that we cannot untangle those social determinants from the advocacy and broader health concerns of LGBTQ people. So we know that poverty disproportionately affects LGBTQ folks relative to the general population. They're more likely to be homeless, less likely to own their own homes. And for those of you who may not be familiar, there is currently no federal protection from housing and rent discrimination. More than half of states still lack laws explicitly banning discrimination against LGBTQ folks in housing. 44% of LGBTQ people of color report an impact of discrimination on their ability to rent or purchase a home versus just 32% of, for example, white LGBTQ folks. Same issue in healthcare to some extent. There's no federal law legislatively enshrined preventing discrimination in insurance coverage in healthcare, but we do have the non-discrimination provision embedded into the Affordable Care Act, which continues to be challenged in the courts. And then certainly a shortage of physicians with sufficient training to treat transgender patients. So with all of that background, I do want us all to start on the same page and really talk about some concepts and terminology here. And my disclaimer is that there is no such thing as universal terminology. Terminology changes, it evolves, different terms resonate with different people in different ways. And most importantly, the term that you use should be the term embraced by the person sitting in front of you. But with that being said, I do want to talk about sex and gender. So sex is known as sex assigned at birth, tends to be based on the appearance of external anatomy at the time of birth, and that may or may not align with gender identity or expression. Gender, on the other hand, is a social construction, and in a binary model like ours, it refers to constructs of masculinity or femininity as defined by a given social order. Ours, again, is a binary model, and the gender identity is not inherently defined by sex. And this context really does matter, and it's not the straightforward conversation that the clickbait headlines would like us to have. And to be clear, there are some conflicting schools of thought on this in terms of whether sex is a biological constant or not. However, we can't even begin to have that conversation unless we define what exactly we mean when we use the term sex. And that's the fundamental problem. There's too many assumptions made regarding that definition, whether it be in research, demographics, on survey materials, policy making, etc. So what is sex and how do we define someone's sex? Obviously, most of us are not karyotyped at birth, right, in terms of our chromosomes, and assumptions are made regarding what is or isn't visible between the legs, quite frankly, and that single observation does set us all on a predefined acceptable social pathway that for those who fit outside of those limitations, it can result in issues navigating about society. And so a few other terms. So cisgender would be when one's gender identity does align with their sex assigned at birth. Transgender, on the other hand, describes someone whose gender identity or internal sense of their gender differs from that based on their sex assigned at birth. And so we can kind of think of a lot of different terms here. We have terms like transgender, non-binary, genderqueer, gender non-conforming, and all of these do have some nuanced meanings to them, but they can generally be thought of as within under the umbrella of gender diversity or gender expansiveness or gender minority. All these are terms that you might hear for that. But so much of this terminology has been conflated over the years. The LGBTQ population is not monolithic, it's extensively diverse. And we have to be clear about who and what exactly we're talking about in research and policy. And so I emphasize what I call the dimensions of personhood as distinct concepts with specific implications for care and general well being. So we have identities, for one, and this refers in this context to things like sexual orientation, gender identity, the intersection between and amongst those in terms of race, ethnicity, religion, ability, all of these different factors. And that funnels into concerns about mental health and stigma, the usage of affirming terminology, and how we build resilience in these populations. But then we also have to think about bodies, right? So, what body, what anatomy does a person have? And that explicitly and specifically impacts things like medication counseling, pregnancy potential conversations, cancer screening, surgical considerations, and complications thereof. But then we also want to know about behaviors. So, what are individuals doing with the bodies that they have? So, thinking about sexual behaviors in terms of not whether someone can become pregnant or not, for example, but what is that actual risk of pregnancy? And then thinking about comprehensive sexual history and sexually transmitted infection risk and prevention. And so putting this all together in terms of just those identity domains, which is just one of the dimensions of personhood we just discussed. On one hand, we have the notion of sex assigned at birth and sex development. So referring to female or male, or also intersex. So when that sex assignment may be ambiguous, and that refers to differences of sex development or so-called variations of sex characteristics. Then we have gender identity, so the internal sense of gender that someone has, whether they identify as woman, man, or non binary, somewhere in between, none at all, cisgender, transgender, non binary, genderqueer, those are all terms that fall under that umbrella. Then we have gender expression. So, how someone conveys that gender identity to the world around them and to themselves. So, whether or not they're presenting in a feminine context, a masculine context, none of the above, whether they're gender nonconforming or conforming. And then, of course, we have the very different role of sexual orientation and attraction. So, all of the terms that you may be familiar with, like lesbian, gay, bisexual, straight, pansexual, all of those types of terms. And queer is a nuanced one, too, that we'll talk about that can refer to any of these identities in some contexts. But putting all of that together, it's important to just simply remember that these are distinct terms and that we should avoid assumptions about them. So, sex assigned at birth is not the same as gender identity, not the same as gender expression, and sexual orientation does not necessarily inform sexual behavior. In other words, we can certainly see individuals who may identify as straight or heterosexual, but they do engage in sexual behaviors with members of the same sex, which can certainly inform risk measures that we take and counseling that we undergo in terms of ensuring, a sex empowered life for them in the most healthy way possible. And so, with that in mind, we of course want to also talk about what we mean by gender dysphoria. So, this refers to that strong and persistent distress or impairment with one's sex assignment that is incongruent with their gender identity. And this dysphoria often results in difficulty navigating comfortably or without discrimination in their world and in their context and throughout their lived experience. Now, not all gender diverse people will experience dysphoria. Some do, some don't. When they do, this is mitigated in part through gender affirmation. And what is gender affirmation? But a set, a compendium of decisions, behaviors, and interventions that affirm a gender diverse person's identity. And there's a lot of components to this, one being self affirmation, so simply internally affirming your own identity. Social affirmation, name changes, pronouns, gender expression, legal affirmation, so modifying gender markers on government documents, medical affirmation, so hormone therapy, pubertal suppression, depending on age and context. And then, of course, we get into surgical affirmation, so the full gamut of procedures, both invasive and minimally invasive, that can be undertaken. Now, it's important to remember that not all people who are gender diverse will want any or all of these domains. They don't have to be pursued in any certain order. There can be going back and forth and all sorts of ways in which someone might do this to affirm their own identity. Now, how do we know how to go about proceeding with gender affirmation? Well, a lot of these standards come down from the World Professional Association for Transgender Health, which is the leading professional organization dedicated to research and development of guidelines for the care of gender diverse people. These standards have been around for decades at this point. The most recent version, version 8, came out in the fall of 2022. This is very robust evidence, contrary to what you may hear, including systematic reviews involving almost 400 studies, and the final standards referenced more than 1,400 studies. And basically, some of the key points in the most recent iteration is that a one size fits model does not work for everyone. Care should be very individualized, and the mental health and psychiatric domains don't necessarily have to function as gatekeeper for this care, but it's certainly important and critical when it is deemed to be necessary. I do want to point out that the only form of gender affirming care for children before puberty is social support. There are no formal recommendations or evidence for doing medical or surgical therapy in this context for children before puberty. So that's something that, has been circulating throughout some state houses, for example, and I always like to demystify that. Now, with all of that evidence, you would think that people would be able to get the much needed and life saving care that they deserve. However, we've seen unprecedented attacks on the ability of folks to get this care in recent years. So, just by way of perspective, as of March of 2021, not a single state banned best practice medical care, and very few states had even considered it. But now we see, as of just a few weeks ago, at least more than 500 anti LGBTQ bills have been introduced across 40 states. More than 100 bills passed just last year. 40% of transgender people in the United States have considered relocating because of discrimination or unequal treatment because of these, and 10% have already, in fact, done so. And in some spaces and contexts, this has really been made akin to somewhat of a mass migration, which has been prompted by all of this legislation. And it's not just healthcare, there's numerous domains of life that have been impacted, ranging from education and then entertainment and other things of that nature that stem far beyond healthcare. This is the current state of the landscape that I present to you here, an overview of legislative activity. And I love talking about the global landscape, but that's an entire lecture all its own. So we're going to focus on the United States here. But basically, this just shows in red those states that have passed some form of gender affirming care ban. And in green, we have the states that have actually enacted what we call shield laws or executive orders to further protect this population. Now, South Carolina could join this list very soon. And some of the good news, though, is that the lower courts have been steadily ruling in favor of transgender people, but these cases are steadily being overruled, making their way into the federal circuit, and slowly potentially inching their way up to the Supreme Court. And so we're definitely looking out for when that happens, when the Supreme Court decides to take up some of these cases. But it's hard to know for sure how much of this directly impacts dermatology, for example. The language in the bills, however, could be absolutely construed as implicating derm care, depending on who's interpreting that language, which makes a huge difference. And in some cases and in some states, are certainly people who have stopped providing this care out of fear of violating the law. There are many multidisciplinary gender care clinics in some states who have stopped providing services, and therefore care is being denied in many instances. And this is having a huge impact on people. This anti-transgender legislation has been shown in some surveys, almost 90% in a recent one of trans and non-binary youth, who said that these recent debates have negatively impacted their mental health, and that is already on top of very disproportionate experiences with feeling unsafe at school, being bullied, being threatened, substance abuse, and mental health issues that are far outpaced in trans youth versus their cisgender counterparts. We've also seen a significant increase in anti-LGBT hate crimes over the last several years, 30% increase in crimes against transgender people as well. So this is certainly not without an impact, and these discussions are reverberating around the country and in fact around the world. Now, I don't want to make you think that this is all negative. There are positive steps happening as well. There are many states, as I mentioned, enacting shield laws, as well as conversion therapy bans or so-called conversion therapy bans, which is fake science, just to put it lightly, designed to so-called correct individuals of diverse sexual orientations or gender identities. And there are increasing non-discrimination protections being afforded, as well as telehealth expansions. So with all of that context, I do want us to talk a little bit about how we go about creating the welcoming and affirming space for individuals of all sexual and gender identities, particularly in this climate. And before we do that, it's always important to set the stage with a framework for how we develop our understanding and our goals for learning. And a term that you often hear is this term known as cultural competence. And this has been deeply ingrained in medical education for decades at this point. I do consider it a bit reductionist and simplistic, and it also seems to normalize socially dominant cultures. And it's also understood as something that can be attained, and it individualizes a failure to do so without taking into account a lot of structural power relationships that really can't be altered on an individual basis. Competence is also measured in terms of learner confidence and comfort, which may have little to do, honestly, with working effectively across differences. So I like to think of this in terms of structural competency and cultural humility. The former, structural competency, really being able to internalize and respond to all of the downstream impacts of power dynamics, legislation, and social determinants, and being aware of power hierarchies. Cultural humility, on the other hand, is really this lifelong process of an interpersonal willingness to learn from others around you and a desire to develop partnerships. It is not just a one-time intervention where we check ourselves off as competent in a given culture and then move on. This is lifelong learning, lifelong exploration, and internal and intrapersonal dialogue. So with that in mind, so essentials of the approach here, several things that we'll talk about: cultivating that affirmative approach, eliciting the patient's story, using the right language, avoiding missteps and apologizing when necessary, and then of course, preserving autonomy. So the first one would really be recognition and affirmation. And this really is simply demonstrating a positive view of these identities and relationships, and really honestly acknowledging the negative influences of many of these phobias, and simply depathologizing sexual and gender diverse people and their identities as well as sexual behaviors, and acknowledging the historical failures of the medical system to meet those needs. So embracing those identities, validating these feelings, acknowledging where the data has been lacking while still treating ethically and appropriately. And this goes a very long way in cementing that rapport. The other thing is the patient's story. So this ties into cultural humility and structural competency to really understand when someone's stories are being silenced or in fact censored, and when privilege provides a microphone. So everyone has a story that needs to be told and needs to be heard, but sometimes those stories are not, and really thinking about why, and really seeking to develop that genuine curiosity about the lived experiences of others, and understanding that we learn about ourselves through learning about others and these life stories that have been built and shaped by prejudice and stigma. And most people do have some element of privilege and some element of non-privilege. And one thing we don't often recognize is that many of these dimensions and experiences can in fact evolve over the lifespan. And the way in which all of these come together to inform someone's lived experience and unique issues with discrimination was set forth in the late 1980s by an important trailblazer named Professor Kimberly Crenshaw, with the term intersectionality in her seminal paper, really looking at how all of these terms kind of come together. Now, she looked at it in terms of the experience of Black feminism in that particular community, but it also has been expanded to look at all of these different variables and how they interact and create unique lived experiences for people. And with these stories, I think it's important to kind of give some historical examples of this in terms of stories that we know about and stories that we don't. So you may, for example, recall from the blockbuster movie many years ago, Harvey Milk. He was the first openly gay man to be elected to public office in California as a member of the San Francisco Board of Supervisors, known as one of the most famous and most significantly openly LGBT officials ever elected in this country. However, folks you may not be as familiar with would be Marsha Johnson and Sylvia Rivera, who were early American gay liberation activists, also identified as drag queens and people of color, were among the most prominent figures of the Stonewall uprisings of 1969, which really catapulted the modern gay rights movement. They co-founded STAR, the Street Transvestite Action Revolutionaries, that provided housing and support to homeless LGBT youth and sex workers in Manhattan. And really, their combined legacy together ensured the pathway to civil rights for queer people for generations, and almost certainly laid the groundwork for Harvey Milk's achievements. And this really just shows the richness, the vibrancy, that resiliency of our community and all of its diversity, altruism, and talent. And it's just simply beautiful stories to tell that should be told more often and that have been silenced largely because of that intersection of skin color and identity. Obviously, we're all very familiar with Dr. Martin Luther King and his incalculable legacy on the world, but someone you may not be as familiar with would be a close confidant and mentor of his, Bayard Rustin, who was a key leader of the civil rights movement and the chief organizer of the 1963 March on Washington for Jobs and Freedom. He proved to be a transformative figure in the fight for racial justice, and he even reportedly introduced Dr. King to the Gandhian principles of nonviolence that would come to really define these struggles. However, he also happened to be gay. And as such, he was kept on the sidelines, wasn't permitted to be near the public face of the movement. But despite that, he had a very important legacy of his own, even foreshadowing a lot of these concepts of intersectionality, noting that if we're fighting for one group, we cannot do that without fighting for all groups that are involved in this fight for equity and justice. And there's been some renewed attention given to him. There's a Netflix documentary on him, which is absolutely incredible. But I encourage you to look at that. And again, just remember the stories that are told versus not told. So thinking about more about language, a few other terms to know. So chosen name would be the name that someone uses, as opposed to their dead name, which might be the name that is associated with their sex assigned at birth when a name change has happened, but it may still be the name listed on government documents. And also keep in mind the role of pronouns and gender neutral pronouns and neopronouns, which are non-binary pronouns used in place of they, them to avoid binary pronoun usage. And I do want to emphasize here, be sure that you are prepared to converse and interact with folks who do not use pronouns or who use non-binary pronouns or neopronouns. I can tell you this takes practice. And so someone who is coming into your clinic setting, or if you have trainees or residents or students or whoever it may be, in order for them to feel accepted and belong, obviously the pronoun usage has to be appropriate for them and affirm their own identity. And that's something that really has to be kind of rehearsed and thought very carefully about. Queer is a term that's been reclaimed and more commonly embraced, especially in the younger generations, but terms to generally avoid would be homosexual, which has fallen out of favor because it harkens back to when it was listed as a pathology in the DSM. Transvestite, transgendered with an ED, transsexual, and then MTF, FTM, or male to female, female to male outside of a research context. So keep in mind that. But also just be aware, some individuals may embrace these terms. I do have patients who identify as homosexual, and that is okay because that's what they identify with, and that's the important language to use. And just also remembering that missteps do cause harm. So when we do, for example, misgender someone, that can cause harm, but it happens. It happens to all of us, regardless of how long we've been doing this work. And that's where the art of the apology comes in. And so important to understand that an apology isn't something that admits that we intentionally did something wrong or that we have a knowledge deficiency. This is about taking responsibility, validating feelings, rebuilding that trust and rapport. And I can tell you that I have had some of the most rewarding patient experiences and interactions when those have been built off of apologizing. There's something very powerful about the apology in terms of showing that dedication and authenticity about wanting to learn and wanting to resonate with someone's lived experience in the setting of that conversation. And then, of course, thinking about autonomy. And it's important that we leave control to the patient in terms of consents, ability to stop or modify exams, even thinking about decisions on abstinence and contraception in the setting of iPledge for those of us who prescribe isotretinoin, shared decision making. And of course, that trauma informed approach is so very important as we acknowledge that and validate anxieties about many of these historical wrongs that have been committed in the medical setting that need to be addressed very openly and transparently. And so the clinic environment is a big part of this as well. And I'll talk about a few here. So staff and personnel training. So everyone on the care team with any touch with patients of any kind, ranging from receptionists, phone operators, front desk associates, nurses, MAs, assistants, residents, the whole gamut all need to be trained in cultural humility and the structural competency aspect to use the right language and to understand a lot of the terminology. Gender neutral restrooms and facilities, and also thinking about the signage, the artwork, the periodicals, and making sure that all of these pictures are not just showing, for example, one aspect of a family unit or what a family looks like or what a relationship looks like, being sure that it appeals to all, is using non-stigmatizing language, and it should appeal across cultures, ethnicities, and skin types. I remember just a few months ago, I was having a conversation with our staff where we have after visit summaries, for example, that summarize all of the approaches to something like androgenetic alopecia, or what's been called in the past male pattern or female pattern hair thinning. And try as we might, if we have a really great conversation about androgenetic hair loss with the patient, and the conversation goes very well, we're using gender neutral terminology, we're talking about these things in the most appropriate way possible, especially for someone who may identify as non binary. But then they get an after visit summary that really just re emphasizes or recapitulates all of those gendered terms and some of those stigmatizing terms that can undermine the entire conversation that you just had. So think about all these different elements that you may not even think of. Of course, ensuring privacy and ensuring that medical records and data collection are inclusive, that intake forms ask about these important things like gender identity and sexual orientation. And some other communication language tips as well here, just a sample kind of thinking about gender neutral ways of addressing patients and colleagues, thinking about asking how we ask about patients' partners and relationship status, and avoid assuming the gender of those individuals, and using the terms people use to describe themselves and only asking for information that's absolutely necessary, right? So a few other things to talk about in terms of this conversational approach would be here. And this is kind of a schematic that I do use very frequently, especially when I need to take comprehensive gender and sexual history. So thinking about current gender identity, how to ask about that in sex assigned at birth and pronouns that folks use as well, the organs that someone has and what terms they use for those organs, have they had surgery, and then asking about their kind of if they're sexually active or not. Is this by choice? Even thinking about whether we screen for intimate partner violence as well. And of course, the genders and bodies of one's partners. How do you have sex with them? What body parts are used? All of those directly inform the care decisions that we make, the risks that they may have, the things that we need to be thinking about in terms of prevention. And then, of course, asking about pregnancy potential, desires for that, and pregnancy prevention. And then on the left here, you can see some terms when necessary for gender neutrality when it comes to describing some of this anatomy. And this comes from the OB-GYN literature, a very wonderful paper focusing specifically on contraception in the transmasculine population. And I encourage you to take a peek at that just because this is something that can be very helpful when using terms that are non-stigmatizing, especially for non-binary individuals. But you'll find an infinite number of suggestions in terms of how to use these conversations and framing these questions, but find the style that works for you and comes most naturally. But a few other examples of this, terms to avoid on the left versus in more inclusive terms on the right. I do want to point out kind of thinking about asking about pronouns, for example, what pronouns do you use as opposed to what are your preferred pronouns or sexual orientation versus sexual preference. Generally avoid the term preference in this space, regardless of context. These identities, terms, and words are the lived facts of individual experiences. They are not merely preferences. And so thinking about avoiding those terms as well. I do want to talk a little bit about education. Certainly, we know that the comfort caring for sexual and gender diverse people does parallel clinical exposure and curricula that are dedicated to these topics. And that's really shown here in these graphs from this very great study in LGBT health from several years ago. And the graphs on the left really reflect the number of curricular hours students are exposed to, and on the right depicts the number of LGBT patients they see. And we see that as both of those increase, the comfort caring for those populations goes up as well. And this has been known for quite a long time. Even the AAMC, with their focus on undergraduate medical education, issued recommendations almost a little more than a decade ago, looking at how to integrate this content and concepts across numerous domains of learning into the medical education space. But yet still, many institutions have not adopted these goals and these policies. And as of several years ago, and even more recently, students continue to report that they receive an adequate education in sexual and gender diverse health. But we've also talked about this very specifically in the dermatology space as well. And we've actually talked about the fact that there are those three critical domains of not only curricula, but also clinical immersion and exposure to sexual and gender diverse patients, but also being a part of an institutional environment more broadly that's inclusive and welcoming. And also remember, I'll kind of dovetail over something that Dr. Akinlami said in that wonderful talk, that this is something where no matter where we are in our efforts, there is always room to improve. So as we think about across many of these domains, there are some things that we might do just to increase awareness, whether it's signage or just a basic acknowledgement that gender and sexual diversity exists. But then we can kind of go the extra mile and have an additive approach, thinking about having mentors in these identities and in these spaces actually being visible and transparent about their experiences, having more integrative inclusion of these topics into our curricula. And then, of course, can climb all the way up to transformative practice and beyond, where we have critical approaches to engagement, truly inclusive practices, role models, and allies, and actually bringing in members of these communities to actually be a part of our work that we do. And with that being said, in the dermatology space, this is just a sample of what a comprehensive curriculum might look like as we think about how to really integrate these topics into our work. We start with core concepts and terminology that we've been talking about here: cultural humility, sexual health, infectious disease, medical dermatology, of course, gender affirming dermatology, management of acne and those taking testosterone, hormone therapy impacts on hair, minimally invasive affirmation procedures, hair removal, soft tissue augmentation, neurotoxins, talking about illicit fillers and the role of that and how we treat it, how we manage it, even looking at things like chest binding. All of those things could be full lectures on their own. But then, of course, having that structural element of societal considerations, advocacy, the legislative landscape, all these are important when contextualizing the challenges that our patients face and that we face as well when providing this care. And these are examples of resources about some of these. There are modules that can be found that are open to the public on the American Academy of Dermatology Basic Dermatology Curriculum website, which I'm happy to provide for you. There are other modules out there kind of talking about how some of these curricula might be designed, and other great papers that are on these points as well, summarizing some of the terminology and definitions. But certainly, I think dermatology has a huge role to play, and there's a gap here where we need to be more visible. And this is some preliminary data where we looked at numerous different centers around the country specializing in transgender health and really showing that of all the different multi-specialty disciplines that can be involved, dermatology is actually the least represented, the most routinely not noted as a collaborating discipline. So something we can work on. Also here in terms of academic gender care programs, this was something we recently published showing that more than half of dermatology residency programs do have an institutional multi-specialty gender program, but less than a third of those derm programs are explicitly offering their services through those multi-specialty programs. Now, certainly there's some methodological kind of gaps that might account for some of that here, but we do know that derm is not as well integrated into some of these institutional gender care clinics as they could be. And it's important for folks to be aware that we provide essential services. And so also thinking about just a little bit more how we do make our clinics, our spaces more open. And part of this is just how we ask these questions, which I don't want the value and importance of this to be underestimated. So for quite a long time, we've been debating about how to most appropriately ask these questions. And for a long time, it was basically asked as just one question: do you consider yourself transgender or not? Or does your gender identity match the gender you were assigned at birth? But we found that for many reasons, that was not terribly appealing and not terribly informative in many ways. So we've moved on to more of a two-step method, as we call it, for asking these questions, in terms of what is your gender identity and what is your sex assigned at birth. And my personal approach, and there's a lot of approaches to doing this, but this is mine. And it goes according to sex assigned at birth and gender identity. And what I like about this, several things. So under the sex assigned at birth, you have sex related words. So female and male. You also have intersex and options, of course, to say I don't know or opt out, prefer not to answer. Gender identity, you have terms that relate to gender. So woman, man, genderqueer, non-binary, none of these. And then, of course, prefer not to answer. So it basically prevents conflation of sex and gender, really shows very clearly what we're talking about. It also normalizes and creates an equal playing field, because if you, for instance, have a question that says, do you identify as transgender? And the options are simply yes or no, that automatically others trans individuals from the conversation and from the space. Whereas these questions relate to all individuals equally across the board. Everyone has a sex assigned at birth. Everyone has a gender identity. So important to think about that, and depending on context. And then, of course, in my last few slides, I just wanted to reinforce a few things and note that there is that spectrum of impact that varying levels of focus on these concepts can have, ranging from outright exploitation and marginalization when there's no focus at all, to just a very basic sensitivity and mere passive accommodations when considerations are minimal, and all the way getting up where I think we should all aim to transformative and inclusion, when inequities are not only recognized, but they're fundamentally understood and mitigated, with marginalized populations, most importantly, feeling a sense of belonging. And even though the notion of DEI has come under fire and we have to use different words in many instances now, the ultimate goal of DEI is to ensure that everyone belongs. And so to truly achieve gender equity, it's vital that these gender transformative approaches be explicit, be intentional, and include these diverse identities in organizational culture, data, policy, and practice. And a few things I want to leave you with. So here, I basically show that there is a lot of work to be done in terms of grassroots awareness of these issues. So what this shows is that only 30% of the US population claims to know a transgender person. To put that into perspective, in 2015, when the Supreme Court legalized same-sex marriage, more than 90% of Americans claimed to know a lesbian, gay, or bisexual person. And that makes a huge impact as we think about people understanding these lived experiences and having an intersection with them. And as we think about how we approach these conversations of the bans on trans care, and from an advocacy perspective, we have to frame that in terms of access to care, and that this is about banning physicians from providing evidence-based care, regardless of the underlying issue, and that should never be something that we're okay with. And then also, we have a lot of work to do to ensure that our trans and gender diverse physicians are welcome. This is really a study showing that for more than 20 trans physicians, they were interviewed in several different ways, in several different settings, showing that there's still a persistence of transphobia and the domination of a binary paradigm and structural and institutional factors that create to burnout and issues with well-being. And so we have to look more about how we can be active allies to these individuals. And really, the last thing I want to leave you with is please get involved in advocacy. It's so important. We cannot untangle it from the care that we provide. The AMA is just one example where we have a host of policy covering all of these issues. We provide feedback and commentary on the advisory committee that I'm on to the World Medical Association, including comprehensive statements for inclusive language. This year at our meeting, we're focusing on gender diverse Indigenous voices, thinking about how we can optimize care for geriatric and older adult LGBTQ populations, and even looking at convening task forces to look at reimbursement issues in this space to further ensure equity there. So please be involved at any level that you can. Happy to answer any questions about that. And this is my summary, which I won't take up your time with, but it'll be in the slides and the recording. I'm happy to share them. But thank you so much for your time, your dedication, your energy, and I hope that everyone feels empowered to do this work. And thank you for such a great symposium.
Thank you, Dr. Peebles. I'm in a different room at this moment, but hopefully everybody can still see me. I appreciate that very comprehensive overview, and something that we all needed to have a better understanding of. Dr. Kanadia, any questions from the chat?
Yes, the first question was, how much do you think the current political climate has contributed to increasing these bans?
So it's a great question. It's had a huge impact, I will say. And not to get terribly political with it, but in all honesty, a lot of this legislative language has been cookie cuttered and stamped across the states in a very strategic way. And I will also be honest and say that there is a subset of individuals in terms of voting blocs for whom it was very strategically identified that a focus on transgender people would be a quote unquote winning strategy. And this is something that has helped to unify some individuals in terms of their ideological or political leanings. So it's been very coordinated, and it has had a huge impact, and it's only continuing as long as it's something that is seen as a rallying cry for certain individuals.
Thank you for that. The final question was, has there been any discussion with iPledge about adding a contraception option that is more inclusive of diverse sexual experiences?
Yeah, it's a good question. I think it kind of depends on what's really meant in that statement by contraception. One thing I will say, I mean, certainly in terms of pregnancy potential, that has been, there was many years of advocacy that ultimately culminated in getting rid of the conflation with pregnancy potential and gender or sex. So now it's just people who can or cannot become pregnant. In terms of contraception, it's a little bit more nuanced just because, quite simply, any form of contraception that a cisgender person uses is still available to a transgender person. For example, there is nothing just in a vacuum about testosterone. For example, transmasculine individuals who still have uterus and ovaries, that means that they cannot use any particular type of contraception. Now, depending on where they are in their affirmation trajectory, depending on where they are with secondary sex characteristic acquisition or stabilization, depending on where they are with surgical planning, and depending on where they are with what triggers their dysphoria and what doesn't, that certainly contributes to the choice of contraceptive agent that you use. But many of these agents are not inherently incongruent with gender diversity. What matters is certainly how we have those conversations and how we counsel and how we go about arriving at the best choice from a shared decision-making perspective.
Very good. Any further questions for Dr. Peebles? Excellent. Well, thank you so much for being with us and just sharing this incredible information with us that we all need to know. And if anybody has any questions that they think of down the road, would you mind, Dr. Peebles, putting your email address in the chat or however they may be able to get in touch with you? I will tell you that this symposium is being recorded from the beginning to the very end. And so about a month later from today, that should be uploaded to our departmental website. And so we can put that in the chat as well. So thank you so much, Dr. Peebles.